Yes, thank you for having me. I think all the rules and regulations are up on that first slide, so let's jump in. This is going to be the funnest lecture you have because in the end, you all want to get paid some way or another, and this is how it's going to happen. So what we're going to talk about is basically coding and documentation basics. I've got several items up here. First, the idea of talking about RVUs because that's how our CPT codes are built. We'll go through some of the basic CPT codes that you're using in neonatology. If we have time, we'll talk a little bit about ICD-10. I'm not sure we'll have time for that or not. And hopefully we can leave a few minutes for questions if you have questions. So how you get paid, CPT and RBRVS. So RBRVS are resource-based relative value scales. The elements of those, which are also RVUs, are split into three different components. Split into physician work, practice expense, professional liability insurance or malpractice costs, and then they take a look at where in the United States you're practicing at. That is the Geographic Practice Cost Index. And then they multiply that by a Medicare global period dollar. So let me show you just a little bit about how that works. So the physician work component's maintained by CMS, and then it has input from the American Medical Association and something called the Specialty Society Relative Value Scale Update Committee. It's just called the RUC. Pediatrics has one spot on the RUC committee. All the different specialties are represented by there. It's kind of almost criminal that pediatrics only have one spot because the rest of them are basically adult medicine and some specialists that have additional positions on the RUC committee. Physician work is really defined as the physician time to perform the service. It includes the technical skill, the physical effort, the mental effort, the judgment, and the psychological stress associated with physicians concerned about the risk to the patient. Anytime that we create a new code, and it's been several years since we've created a new code, they actually send out a survey to those of us who do a fair amount of work within the coding and billing realm and ask us to judge this code compared to other codes. And these are the types of things that we think about when we're trying to determine what the physician work is. The practice expense is about 44% of the total RVUs for each service. That's in the adult world. In our world of neonatal ICU, we typically have a low practice expense. If you're in a private practice by yourself, your practice expense is minimal. It's probably computers, office space, billing clerks, software. For a private practice, general pediatrics, you have a lot more overhead. You've got overhead associated with having to lease a building, with having to provide staff with nurses, MAs, with all the different supplies that you have to have. So even though I say practice expense is 44% of the total RVUs, that's not necessarily so for us. 1998, some CPT codes were given two different practice expense, one lesser one for procedures performed in a facility, that is in a hospital, skilled nursing facility, or an ambulatory center, where the hospital, skilled facility, or ambulatory center covered a lot of the practice expense. And then a greater one for procedures and services performed in a non-facility site, like your office, again, if you were in private practice. So the biggest component of this is always going to be, for our code, it's going to be physician work, a little bit less for practice expense, and then the idea of professional liability or malpractice. So those expenses are relative values, and they amount to about 4% of the physician fee schedule payment. Medicaid is required to review and adjust these every 5 years, at least every 5 years. I know that there are some states that are more litigious than others. Kentucky is a state where the malpractice climate, if you consider one being a standard across the United States, the malpractice climate in the state of Kentucky is about 0.89, I think. Next, they take a look and see where you're practicing at. It doesn't take a whole lot of guesswork to figure out that if you're in practice in Los Angeles, Chicago, or New York City, your costs are a lot higher than mine are in Louisville, Kentucky. And so they'll take those things into consideration. Again, if you would consider that Louisville, Kentucky as a 1.0, that's the baseline. For somebody who's practicing in LA or Chicago, it may be a 1.3 or 1.4. And so they'll use that as a multiplier to increase the amount of RVUs, hence increase the amount of payment that's coming to the physician practices. And here exactly is what I have. In Kentucky, if I take a look at the geographic practice cost indices, you'll see that work is a 1.0 because I have to put in the same amount of work whether you're in LA or Chicago or New York. My expenses for practices are a little bit less, and my expenses for professional liability insurance is a little bit less. So you take those components, the work RVUs, the practice expense, the malpractice expense, you multiply it through by those geographic practice cost indices, it gives you a total amount of RVUs. You then take these total RVUs and multiply it by a conversion factor. This year, the conversion factor is $33.28.5. So those are set up by CMS. They're set up to be budget neutral. And in fact, this has got to be, we continue to see declines in the conversion factor over the last 10 years or so. This has got to be one of the lowest conversion factors, again, because it has to be budget neutral. Congress and the president can go in and adjust that conversion factor. The actual conversion factor for 2024 was $32 and change, and they went back in and increased it back up to $33 and change. So while we took a dip in those conversion factors, that the payment per RVU, at least they're higher than they were originally planned on being. What they also did is they went back and they looked at a lot of primary care codes and they give them higher RVUs values to kind of offset that and try to increase the payments for some primary care that were otherwise undervalued. So that's what an RVU is. So each CPT code has a set number of RVUs associated with it. There are three types of CPT codes. We're only going to mention the type 2 and type 3, but there are three codes. The category 1 codes are what we use on a regular basis. Category 2 codes are performance measurement codes that you won't have anything to do with. Category 3 codes are emerging technology. They're typically temporary codes that are put in place, evaluated for usage, and then put forward to see whether or not they would become a permanent code. So let's talk just briefly about a category 2 code because we're not going to use those much. Category 2 codes are intended to facilitate collection of information about quality of care. So it codes a number of tester services. You see the example I have on here is code 0500F. That is coded at the first prenatal visit. It includes the date of the visit and the last menstrual period. That ultimately is a quality measure. It has nothing to do with how you're reimbursed at all. Category 3 code is where we do data collection and utilization tracking. And so each procedure must be involved in some sort of ongoing or planned research. Here's the last category 3 codes that neonatology had. Cooling. We came out with a category 3 code, and it may have been that 0260T, I don't remember because it's been several years ago, but we created a category 3 code that looked at total body cooling and selective head cooling when cooling first came into mainstream. That's got to be 10 years or more ago. We used that code for several years before they converted it to a category 1 code. So these are temporary. They're retired if the procedure or service isn't accepted as a category 1 code within 5 years. And that code was accepted as a category 1 code. I don't remember if I have any examples in here for cooling, but I'll at least mention it as we get into things a little bit further. So since we want to talk about coding and billing, let's talk about the most commonly used CPT codes. The most common things, let's start at the beginning, is going to be attendance at delivery. So there's 2 CPT codes for attendance at delivery. Those are 99464 and 99465. These CPT codes define attendance and newborn resuscitation. You see the difference that I have up here, that an attendance at delivery code is when you go in, all you have to do is wipe the baby off. You can apply CPAP, do a history, a physical examination, and create a plan of care, and then you can move the baby wherever they need to go to. If that baby requires positive pressure ventilation or chest compressions, then you've moved it up to a 99465, which is a newborn resuscitation code. CPAP does not equal resuscitation. It has to be positive pressure ventilation or chest compressions to get to that 99465 code. On any delivery room note, you need to make the following notations. You need to put down who the referring physician was, the reason or indication for the referral, meconium stained amniotic fluid, a brief history. The mother was a prima gravida, group B strep negative, prenatal labs were negative, that was ruptured for 5 hours and proceeded to vaginal delivery. An examination following the delivery, and it doesn't have to be a complete exam where you go on every single system, but it needs to be a thorough enough exam to demonstrate and to support the amount of work you did in the delivery room. And then an ultimate plan of care, admitted to the NICU on assisted ventilation, transferred to newborn nursery following kangaroo care with the mother, whatever it might be. So those are your 2 delivery room codes. Those are the 2 codes that you will use the most. And these are the basic elements that you have to have within your notes. Now, most of our procedures, as we get further along, are bundled procedures because our daily codes are what they call global codes. Our daily codes cover a 24-hour period and encompass all these different procedures that we might do. If we get a transport from LaGrange, Kentucky, for example, I bring him into the unit. Sorry, I'm on the ambulance route too. If I bring him into the unit and the baby needs an arterial line placed, that's going to be captured within my global code. But in the delivery room, those codes aren't bundled together. So any procedure that you do that is part of the resuscitation effort, the baby was a meconium stained fluid and came out and was flaccid and required positive pressure, and you subsequently decide to intubate the baby, you can bill separately for that intubation. In that brief example, your code set would be a 99465 resuscitation because I provided positive pressure ventilation, and a 31500 I'm going to bill separately for the intubation. If I waited to intubate after I got baby in the unit and it wasn't part of the resuscitation, I can't bill it there because it's going to get captured within the admission code, the global daily 24-hour code. A couple examples of things that aren't necessarily bundled into the delivery room procedures. Here's a code for UVC placement, 36510. There are also codes for UAC placements. Here's a code for surfactant administration, which has to be done as part of the resuscitation. It's not necessarily something that's done as a routine in the delivery room. Some folks will say, well, if I've got a 25-weeker, we intubate and give all those kids surfactant. You can't bill for that. You got that 25-weeker whose heart rate's still 60, you've been bagging, you're sure you're in place, your tube's in place, you put a line in, volume expansion, still not responding, you decided to give that kid a dose of surfactant, that's considered a resuscitative effort, you can bill for that. So remember in your delivery room, if you do procedures that are part of resuscitation, you can bill for those types of procedures. So here's an example. And I know we got 3 or 4 people online. A neonatologist attends a spontaneous vaginal delivery of a 1.05 kilogram 28-week infant. Chorioamnionitis is suspected. Resuscitation requires drying suction, stimulation, and mass CPAP. Due to a heart rate less than 100, positive pressure ventilation is provided via Neopuff with a good response, APGARs of 4 and 8. The infant stabilized on nasal bubble CPAP and admitted to the NICU. A UVC is placed for antibiotics and early parenteral nutrition. So in addition to the initial critical care code, which we'll get to in a minute, what things could you code on this baby? I've given you 3 choices here: delivery room resuscitation, attendance at delivery, and a UVC, delivery room resuscitation, and the UVC. So the answer for this is simply the delivery room resuscitation. Scenario as it was presented, the baby's admitted and the UVC is placed after admission to the NICU, but you did provide positive pressure ventilation for that baby. So this is a graph that we used the NRP on, and then we created it and we color coded it because everything you needed to know you learned in kindergarten. We decided we wanted to color with it, right? So these types of things here where you're looking at warm, dry, suction, physician airway and suction, post-resuscitation care, all these are going to fall under this 99464 intensive delivery. They are the initial steps of neonatal resuscitation, including blow by oxygen and CPAP. If you have to do positive pressure ventilation, consider cardiac monitoring, you're going to do ET tubes or laryngeal mask, you're going to do chest compressions, you're going to push drugs, you're going to push volume. All these things now fall under the resuscitation codes. Positive pressure or cardiac compression, CPAP alone is not included. The UVC is not part of it, then you don't code for that. If you needed to place a UVC because you needed to do volume expansion in delivery room, you can code for that. Okay, so we started off in a delivery room. Let's go to the newborn nursery. There are really three basic codes you need to know for the newborn nursery. That's the initial history and physical examination, which is 99460. Subsequent day in a normal newborn nursery, a 99462. Admitted and discharged on the same day. How does that happen, you say? I'll tell you in a second. A 99463. And then I put a discharge day of less than 30 minutes in here. There's another code for discharge day greater than 30 minutes that we'll address later. Most of the time, the newborn nursery, I'm charging this lower discharge code. So a term baby is admitted to the newborn nursery on Sunday afternoon. You first see the infant on Monday morning. You do a complete history and physical, finding no concerns, spend 35 minutes with the parents. You anticipate discharge the following day. So what day is the correct one to code? Can you code for Sunday with an initial code and a follow-up code on Monday? No charge on Sunday, a follow-up code on Monday. No charge on Sunday, an initial code on Monday. No charge on Sunday, admission and discharge on Monday. And I did see somebody put something into the chat for the last one, so please do so. I'd love to see what you think the right answer is.
Is it C in this one? No charge Sunday, initial charge Monday.
Yes, absolutely. So the patient wasn't initially seen by the physician until the day after birth, so there were no billable services on a Sunday. Let me hold that one for just a second, because if you're out and you're an attending physician, and like University of Louisville Hospital, that's a smaller NICU, it's a level 3, it's part of our healthcare system. We service all the hospitals in this area, but the fellow admits a kid into, doesn't matter, well baby nursery or NICU on Friday night because they took call, and I don't come in and see the baby until Saturday. They've called and talked to me about the baby. I still can't bill for Friday. My first day of seeing that patient, actually providing a service as an attending physician, is on that Saturday. We're going to see that comes into play when we talk about initial critical cares and initial intensive care days. So this baby wasn't seen until the day after birth. There were no billable services on that Sunday. That was the first day that newborn care was provided. So the 99460 on Monday is correct. And 463 is if you admit him and discharge him on the same date. Let me address that one a minute, because I didn't put another question in there, but we've oftentimes put questions at Scottsdale meeting where we'll bring a baby in on a Sunday afternoon, is seen by the physician on Monday, and the parents want to go home Monday afternoon. If a baby looks okay, you decide they can go home the day afterwards. You've only provided services on that Monday. You can use that 99463. You don't use the 460 initial and the discharge code. You use this in and out code 99463 if you admit them and discharge on the same day. What if it's really not a well baby? We've all got kids, and of course with couplet care, a lot of the newborn nurseries have gone by the wayside. I'm old enough, we used to take care of a lot of things in the newborn nursery. We don't anymore. But what if it's not a well baby? What if this is a baby that's jaundiced and now requires phototherapy? Well, there's a different code set for that because it's not a well baby, so it doesn't use that 99460 codes. It uses these hospital-based codes. These hospital-based codes are 99221, 222, and 223. These are codes for the first day of hospital inpatient care. Things like getting phototherapy, having to monitor blood sugars, perhaps given dextrose gel, maybe a late preterm baby that you have to put in an isolette, but you're willing to keep them in mom's room for 24 hours, whatever it might be. These are the types of things that you would use these hospital codes for. They can be determined either on medical decision-making or time. These sets of codes are going to come up later when you think about doing consultations and follow-up consultations as well, particularly in the prenatal world. So medical decision-making for these low codes is straightforward or low complexity. The medium code is a moderate complexity, 55 minutes. The 223 is a high complexity, 75 minutes. And I think I have on here that'll help us define how you determine medical decision-making. The following day, if you go in, this is still not a well baby, you use subsequent hospital day codes. These are again remember these were done under 221, these are done under 99231, 232, and 233. And all of these you have to either meet or exceed a time frame, or you have to document the medical decision-making in the straightforward low, moderate, or high complexity. This is an important set of codes because this is the same code you use for non-critical babies that are over 5 kilograms. You'll see why that is in a few minutes. So a pediatrician rounds on a 4.5 kilogram male who's 24 hours of age. His parents requested and consented to circumcision. On exam, the pediatrician notes no abnormalities. The OB is contacted, performs the circ. An hour later, the nurse notifies the pediatrician there's a moderate amount of bleeding on the last circumcision assessment. Pediatrician re-examines the infant. If the gauze is fully saturated with bleeding, the pediatrician applies manual pressure, then gel flow, but the bleeding persists. They request urology, who puts a few sutures in. If it stays in the nursery for vital sign monitoring and circumcision site assessment, no further bleeding is noted, but you get a CBC, H&H platelet counts are all fine. Documented time is 75 minutes. So there's several sets of codes that you could use for this encounter. Would you use a 99462, which is the evaluation and management of a normal newborn subsequent day? 99232, which is a subsequent hospital day, moderate decision-making or greater than 35 minutes. A 233, which is a subsequent hospital day with high medical decision-making greater than 50 minutes. Or an intensive care code, which is a weight of 2.5 to 5 kilos. Give you a second to look at that again. So this is no longer a well baby, and well, I would suggest that in that scenario, you would use a 99233. This is a subsequent hospital day greater than 50 minutes with a high level of medical decision making. Now, remember one of the first things I said about this code set is that you can either do it on medical decision making or you can do it on time. This particular patient took you 75 minutes of time. So you can do this code based on the total time that's documented. This is a not so normal baby with a bleeding circ that required intervention, surgical ligatures pushed by a urologist, and the urologist is probably going to charge for that as well. So remember, in these babies, it's either time or medical decision making. Now, let's look real quick at the concept of medical decision making. So medical decision making is based on 2 of the 3 elements of medical decision making. I've already talked a little bit about time. So the total time spent on the data service includes face-to-face and non-face-to-face time directed to the care of the individual patient. It has to be documented on your progress note. When you're thinking about medical decision making as opposed to time, 3 major components here: the complexity of the problem, the data that's being analyzed, and the risk to the patient, either from the condition itself or the treatment you're applying it to. Medical decision-making is applicable to consultation, to office work, if anybody's doing neonatal follow-up, and to hospital care as well. And I've already given you 2 examples of hospital care where you would use these types of codes. First being the not so normal newborn, the second one being the intensive care baby who's over 5 kilos. So in the type of problems, minimal or low is like 1 self-limited or a minor problem, 1 self-limited or minor problem that's not resolving, consistent with definitive or prescribed course, a stable chronic illness, an acute uncomplicated illness. I'm not going to go through every one of these and read these whole slide sets to you. You can find these things online. If you actually Google medical decision making and ask for images, you'll find them images that are already set up into nice tables that goes through the different levels. And this one is just simply related to the problems. Here's a high with an acute or chronic illness that poses a threat to life or bodily function. Data analysis is separated into 3 components as well. And if we went back and we looked at these, we said, okay, there's minimal or low, there's moderate, there's high. Now in data analysis, there's also this minimal or none, limited, moderate, or extensive. And in order to meet those, you see 3 categories. It's like a hatched a chart here that they have to meet. In moderate, for example, they have to meet one of the 3 categories. And here's the 3 different categories: test, documents, and independent historian, any of those 3. Category 2 is independent interpretation of tests. Category 3 is discussion of management or of test interpretations. So if that baby, for example, that we used with the circumcision bleeding, we got H&H and we got a platelet count. So we can take a look at those as independent interpretation of the test. And remember that a decision not to order the test is a decision. It's just like one of those complicated things that I'm talking to residents and fellows about. One of the most difficult things we have to do is to have patience. The decision not to do something is a decision that you've made. It's okay sometimes to wait and see what's going to happen. Whatever you end up ordering, your documentation has to support that that test was considered and discussed and not ordered. Risk is a little more difficult to determine, but here you're thinking about the risk of patient management. You're thinking about potential morbidity. I do circumcisions. It's not my favorite thing in the world because I think, uh-oh, what happens if I screw up somewhere or another? I consider that to be a morbidity, right? Drug therapy requiring intensive monitoring for toxicity. Think about the use of gentamicin for a long period of time where you've got to draw gent levels after a period of time. Surgical risk factors, patient risk factors, or procedural risk factors are all different examples of risk. So that's our decision making. If I've got to get, if I decide that this is a moderate level of decision making, I have to have 2 problems I'm dealing with, a limited set of data and a risk that's low perhaps, but 2 of those 3 have had to hit that moderate category for me to be able to bring it up into the moderate level of coding. Now the codes you're going to use most are intensive care and critical care codes. Let's start with the intensive care codes. 99477 is an admission code. It requires continuous monitoring. The baby doesn't require any support that if stopped would lead to imminent death. That's an important line in there. The baby doesn't require any support that if stopped would lead to imminent death, because that is part of the definition of critical care. Our subsequent day codes are weight-based, which I say makes them pretty idiot-proof. Even I can figure out if the kid's 1,430 grams and is just on a monitor and maybe getting tube feeds and an isolette, he's 1,430 grams. This is the code I'm going to use. This is 99478. He's not got a life-threatening illness. He's being fed and grown and that sort of a thing. So here's our weight categories for a 478 less than 1,500. A 479 is 1,500 to 2,500. 480 is 2,500 to just shy of 5 kilos. If they're over 5 kilos, we're going to go back to those hospital code sets, the 9923, 231, 232, 233. So here's a question for you. A full-term baby born vaginally to a mother whose group B step positive ruptured 3 hours, no natal antibiotics were given. The baby's rooming in with the family. On day 2, the baby has a temp of 101. Baby remains stable and is transferred to the NICU for further care and started on continuous monitoring. Cultures are done, antibiotics are started, and the baby continues to feed by mouth. So the correct code on your NICU admission would be 99477, 99479, 99480, or this 99233. So on this one, the 99477 admission code. One thing to note on here, the initial day does not have to be the day of birth. You can only get one initial intensive care code by a single group practice per hospitalization. There are some other nuances to this. Let's say that same baby had been seen at well baby earlier in the day, and the physician that saw them was part of your group and dropped a well baby code first day 99460, got sick later on the day you decided to admit them and requires this code. You can't code both of those together. The elements of 99460 are considered a part of the elements of 99477. So let's look at this one. A 3-kilogram term baby is born with a known prenatal diagnosis of an isolated cleft palate. The rest of the exam is normal. The baby's vigorous. She's admitted to postpartum to room in with her family. She's feeding poorly. You decide to admit her to the NICU for continuous monitoring and feeding interventions. Her stats are fine. She feeds poorly, and a G-tube is placed. On the following day, you trial her using a Haberman nipple. She remains on a CR monitor and takes 50% of her feeds by mouth. Correct code for this baby: 469 is subsequent critical care, 99480 subsequent intensive care, 462 subsequent newborn care, 99232 subsequent hospital care, moderate decision making. So for this baby, we're going to use the 99480, the intensive care subsequent day, with a weight of 2501 to nearly 5 kilos. These are used for babies who are 28 days or younger, not critically ill, but require the intensive care observations, frequent interventions, and other intensive care services. I should probably take the 28 days or younger out because that's not applicable in that code set. These services include the intensive cardiac and respiratory monitoring, continuous or frequent vital signs, thermal regulation, enteral and parenteral nutrition adjustments, laboratory oxygen monitoring, constant observation by the healthcare team under direct physician supervision. Let's look at a different example: a 5.1 kilo, 4-month-old former 26-weeker with resolving apnea, prematurity, bronchopulmonary dysplasia, and feeding difficulties, remains in the unit under continuous monitoring for apneas, on 1 liter nasal cannula, chronic diuretics, nippling 40% of feeds. The infant tires easily and has increased work of breathing. On exam, the baby's active, mildly edematous, and event retractions with activity in rails. Chemistries and chest x-rays show stable hyponatremia and worsening pulmonary edema. Neonatologist adjusts the diuretic dose and restricts the fluid intake. Total documented time is 50 minutes. So the question is what code set would you use here? Would you use a subsequent critical care day for a baby that's over 28 days of life, the 99472, a subsequent intensive care day, the weight of 2,501 gram to 5 kilos, 99232, subsequent hospital day greater than 30 minutes or moderate medical decision making, 99233, a subsequent hospital care per day meets or exceeds 50 minutes or high level of medical decision making. For this one, we've kind of given it away because we said that there's 50 minutes care there. You have to meet or exceed that. So even if you decide you haven't met the threshold on medical decision making on that particular patient, you've met or exceeded the time-based code. Again, it's either the complexity of the medical decision making or the time-based code. You have to use a hospital-based code because we said the baby was 5.1 kilos. That's over 5,000 grams, and our intensive care codes no longer apply. I think there's one more in here. A pediatrician requests a consult on a baby in the newborn nursery from neonatology. The infant's 2-hour-old with temperature instability and grunting. The neonatologist is tied up, so the neonatal nurse practitioner, who's part of the group, sees the baby. The NP reviews the mother's chart. The mother had a fever during labor. Group B strep unknown. They recommend a complete septic workup and transfer to the NICU. The APP calls the neonatologist, who agrees with the recommendation. The APP speaks with the mother and calls the pediatrician, spending 25 minutes total. On admission to the NICU, the neonatologist completes the H&P and LP and writes the order. So I threw in the idea here of what about relationships with advanced practice providers, neonatal nurse practitioners. We have physician assistants with us. These, first thing is these are not trainees. These are not residents. These are not fellows. So your relationship with a neonatal nurse practitioner or PA is different than it is with a trainee. On this case, I have the APP who's part of the group seeing the baby, correct code would be either A, where the APP does a consultation code, the neonatologist admits under an initial critical care. B, the APP does a consultation code, the neonatologist admits under an intensive care code. C, the neonatologist just does the intensive care code. Or D, the neonatologist takes both codes because the APP called the neonatologist. Thoughts on that one? Somebody's got a bite. So this is one of the nuances I threw in here, and I threw in on purpose. Correct answer for that particular scenario is C, the 99477 code. Once you get out into practice, somebody in your practice needs to have some awareness of what's called the National Correct Coding Initiative, the NCCI. These things are produced quarterly, and it says, this is a great example of it, you can't bill a consultation code and an initial intensive care code by the same group on the same day. So the code that takes precedence is that initial intensive care code. It's a global code. The LP is bundled, so you can't bill for the LP. It's like if you had been taking care of that baby in well baby and 6 hours later decided to admit it to the NICU on the same calendar date, you can't do the well baby code and the intensive care code. So be aware there's some nuances with how you work with nurse practitioners, physician's assistants, the advanced practice providers, that's different from how you would work with residents or fellows. So let's move to inpatient critical care and time-based critical care codes. Critical care codes suggest that a high probability of imminent or life-threatening deterioration can occur. It involves high complexity decision-making to assess, manipulate, support vital sign functions to treat single, multiple, or vital organ system failure. Prematurity alone does not constitute critical care. So even if that baby is 28 weeks, once they come off the vent, you've got them on a liter nasal cannula. We can talk about how much nasal cannula to provide critical care if you like. But you've got them on a little bit of nasal cannula, tube feeding, you're growing them up. Prematurity does not constitute critical care. Here's the 4 sets of critical care codes that we can use. So these are 99468, which is the initial critical care day, less than equal to 28 days. Remember, your first date of life, the date of birth is day 0. So in fact, we really get 29 days. Start with day 0 and then run through 28. 469 is a subsequent, less than 28 days. 471 is 28 days to 2 years. 472 is over 28 days. Also note that I have on here, and I've mentioned it with the intensive care code, the initial critical care may not mean the first day of life or the admission code. You may have admitted this baby in well baby, he looked okay. By 6 hours, he was starting to get tachypnic. The next day, he developed DIC and what looked like fulminant sepsis and got intubated. So now a day and a half later, you get an initial critical care code in that type of scenario. So here's a baby that was admitted, I've got this over my screen, I can't see it, by C-section to a prima gravida with preeclampsia with severe features, requires positive pressure in delivery room, followed by CPAP and admission to the NICU. He's put on bubble CPAP, +5 and 30%, birth weight is 1,600 grams. On day 1, he's on CPAP, weighs 1,590. In subsequent days, his distress improves, and during rounds, day 2, you changing to a high flow cannula at 3 liters for CPAP effect. By day 3, he weans to 1 liter nasal cannula with continuous monitoring. By day 4, he's still on 1 liter. His weight's down 1,490. So on day 2, he is on high flow cannula at 3 liters for CPAP effect. Where would you code him on day 2? This is a subsequent critical care code. This is a subsequent intensive care code of 1,500 to 2,500. This is a time-based critical care code. This is the intensive care code for less than 1,500 grams. So a couple of people have said A. In fact, that's exactly what you would do. So respiratory support used to treat respiratory failure is considered critical care. There is no standard that requires a specific flow rate of oxygen by high flow cannula that supports treatment that was critical care. The idea is that you're using high flow nasal cannula for continuous positive airway pressure. And in fact, you should document that in your note. When you see my notes, it'll say the infant's on high flow cannula 2 liters. The infant's on high flow nasal cannula for CPAP effect due to respiratory distress syndrome, due to respiratory failure, due to whatever. Each individual practice kind of picks their mark as to what they label as high flow cannula for CPAP effect. You know, and I know that a 3 kilo kid's not the same thing as a 900 gram kid. Even though both of them may be on nasal cannula at 2 liters, we have opted to use that as our cutoff. If you're on 2 liters or more, you're getting a critical care code. And part of that reason is because if you start using different flow rates for different babies at different weights, you're going to confuse the reviewers, the people that review the insurance. So we said, if you're on 2 liters or more, we're getting high flow cannula, or we're getting CPAP effect into our note, and we're going to charge that out as a critical care. Peter says, phew. Yep. So I mentioned bundle codes. The idea of bundle codes was to avoid billing individually. Our critical care codes are all bundled. These are elements that are bundled: your peripheral venous catheters, your OG tubes, your intubation, spinal taps, bladder aspirations, bladder catheterization, surfactant, central venous catheters, UACs, UVCs. So you can't bill independently for those using a global code. What you can bill, PICC lines, you have to perform CPR. If you intubate or do a laryngoscopy in the delivery room, chest tube is not considered a bundle code. Needle aspiration of the chest is not considered a bundle code. Exchange transfusions has a separate code for that sort of a thing. Actually, the last code we created was for a partial exchange transfusion. Here's a list of bundled codes that we put together for Scottsdale. So you see, there's a whole laundry list of things you can't code for. AMA produces a CPT book, and I get it about every other year. Primarily, I get it because of chairing the coding committee. But these procedures are listed. These are things that you can't bill for in addition to the global code. So let's look at another baby. This is our baby is a 35-weeker on a liter nasal cannula and IV fluids for hypoglycemia, 1,720 grams birth weight. Fluids are increased to 120 per kilo on day 1. Sodium's 132. You add sodium to the fluids. Initial blood count shows a thrombocytopenia with platelet count of 80. By day 2, the infant's hyponatremic to 124. Platelet counts are now down to 22,000. You decide to place a UVC, increase the GIR, and transfuse platelets. In a blood culture, antibiotics transfer the infant to a higher level NICU. However, you live up closer to Michigan, and transport's not able to come because of weather. So labs are doing every 6 hours. You follow the sodium and the platelets. Based on the lab work, you've done frequent adjustments to the sodium content and the IV fluids and GIR while awaiting transfer. So correct coding on that day, which is day 2, while you're waiting for the transfer to come in. Could you build the initial critical care code, 468? Would you do a subsequent code, which is a 479? Would you do a subsequent critical care code, which is a 469? Would you do a subsequent hospital code, which is 99233? So this is a great scenario because the coding committee felt that I pulled this directly off one of the Scottsdale questions. The coding committee felt like this was a sick enough baby to say that the nature of care being delivered, the condition of patient reached critical care levels. That kid had a platelet count of 22,000, that would reach threshold for critical care. First day, critical care, you'd use the 468. Looked okay the day before, but it's the second day of life, he was getting sick. So you can use that first day critical care code. Remember, it's high complexity decision making. It requires single or multiple organ failure, prevent further life-threatening deterioration. These are actually the types of things that are in our attestation statements for critical care. Our attestation statements will read something like, rounds were performed with the resident and the fellow. The infant is critical because of requiring CPAP. The baby stood to use require these things: high complexity decision making, treating multiple organ failure in order to prevent life-threatening deterioration. That is actually components that we have in our attestation statements that are macroed. I have to put a new macro in every day, but those components are in our attestation statement. The other thing is that any physician or specialty can provide those services. As a neonatologist, you're not sole owner of those neonatal codes. If I think the pediatrician that I have out in Litchfield, Kentucky, that's intubated this kid and managed them until we can get down there and take care of the baby, they can use the critical care codes. There's nothing that says that those codes are our ownership per se. So any physician or qualified healthcare provider can do those codes. Documentation. Critical status is not to be inferred. There has to be bedside direction and supervision of care. You should review historical information. A focus examination. This is another interesting comment because in years gone by, those hospital codes said how much examination you had to do. There are no examination requirements for critical care. Your documentation should support the level of care you provided, but there's nothing that says you have to report cardiovascular, respiratory, abdominal, integument, neurologic, and eyeballs. The exam has to show that the infant was critical, and the components of the examination have to demonstrate the illness, the degree of illness of the baby. For the residents, I use, for example, the kid who's come in with hypoxic ischemic encephalopathy is now being cooled. I get on the residents, you need to make sure you have a full neurologic examination on that baby. You can't just put normal strength, tone, and symmetry or flaccid or whatnot. There needs to be a full neurologic exam on a kid with encephalopathy. Let's look at another example. Here we're going to throw a twist in because we bought a baby in for meconium aspiration, failed conventional management, including inhaled nitric oxide. It's put on ECMO. The NICU team has a separate team of special training and expertise in ECMO management in collaboration with the surgical team. The baby's placed on veno-venous ECMO. Surgical team places the cannula. The NICU team manages the ECMO circuit. So what codes does the neonatologist choose for this particular encounter? There's 3 code sets on here: 468, which is a first aid critical care; 946, which is initiation of veno-venous; 947, which is initiation of veno-arterial. Or can you use both a critical care and a veno-venous ECMO code? So the first answer was A, the first day of critical care admission. And in fact, you can use the ECMO code as well. So ECMO codes are considered add-on codes to critical care charges. You'll get the critical care code, but there was recognition by RUC when they created these codes that ECMO and cooling required a higher level of care than our standard critical care. So on a kid who's going on ECMO, you get not only the critical care charge, but you get the ECMO charge too. In this scenario, the surgery team is the one who put in the cannulas, so they're going to bill separately for the cannulas. This is an example of an add-on code. Here are ECMO specific codes. So here's your initiation of veno-venous. Here's your initiation of veno-arterial. You get an add-on code for daily management. So these are going to be billed as a 99469 subsequent critical care. Plus, in this scenario, on a veno-venous circuit, you get this code as an add-on code. This adds additional RVUs. It creates additional payment for the practice. This one is a time-based critical care code. The only time that you would use these, it's a rare occasion that in Louisville that I'm transferring a kid out for additional critical care services. But if I can think of a couple of quick examples, if I was going to send a kid to Cincinnati because the baby required a gut transplant, or perhaps my ECMO circuits are full, I don't have another ECMO bed available, I need to send them to Cincinnati for an ECMO circuit. Then you would use these critical care codes that are time-based. So a 99291 is the first 30 to 74 minutes. You have to reach a 30-minute threshold for that. And then a 99292 adds additional 30-minute to it. So as you create these times to think of how long you spent providing critical care, you continue to add those codes. So this, for example, on the bottom, a 99291 times 1 and then 292 times 4 covers 165 to 194 minutes. In these time-based critical care codes, these things don't have bundled procedures with it. So in a kid who is sick and you're down in Litchfield, Kentucky, because they have a level 2 nursery and you decide the baby needs to be intubated, he needs an arterial line put in place, and you're going to send him to Louisville, and we're a different group covering that nursery there. And it has to be different groups. It can't be the same group. A different group, and you can bill for the time that you spent caring for that baby prior to transfer using these time-based codes with this caveat. You have to subtract any time that you've done procedures with it. So in a kid you've worked on for 2 hours, but it took you 30 minutes to do the intubation and the arterial line in him, your critical care time is really only 90 minutes. And then you can bill for that intubation and the line placement as well. I think that's what I have on this question. At a level 2, the APP employed by a neonatology group attends a delivery for a 28-weeker, requires resuscitation, intubation, positive pressure. Calls the neonatologist, gives an update, and then calls the level 3. The APP manages the vent, the IV fluid, writes the note. The regional level is covered by a different group than the APP and the neonatologist who's covering. So what we've said is that it took a total of 60 minutes time in through here. I've given you some different opportunities for billing with the delivery that require positive pressure would be a 465. The Neo gets no code out of this because the Neo did nothing. So I'm going to give you the answer for this one. The Neo did nothing to this at all. So all these codes are going to be from the APP. So they get the critical care code, they get the intubation code, they get the time-based code. This should be A. The neonatologist gets no code because the neonatologist didn't provide services. Since they never examined the baby or wrote a note, there's no charge. The delivery room charges belongs to the APP. With the neonatology different groups, the referring provider can charge for the critical care. There's another one with the on-call pediatricians that says asked to assist in the emergency department. The EMS dropped off a newly born baby from the birthing center. By the way, I love birthing centers. It's like a guarantee to have a NICU admission, right? The first practice I had was Savannah, Georgia. We had the Richton Birthing Center, and you always guarantee whatever was coming from there was a disaster. If it's pale, grunting, lethargic, the dad said it looked like there was a lot of blood. The heart rate was 190. They suspected an abruption or cord accident. The pediatrician places a UVC, gives a normal saline bolus, intubates the baby, calls for transfer. Pediatrician spends 80 minutes. Where I said you got to pull the time out of that. So in fact, what you're going to be able to bill for is about 70 minutes worth of time here. Code for the activity would be the 70 minutes plus the intubation and the UVC code. IV fluid administration, I don't think is applicable in that setting. So the time-based code for the first 30 to 74 minutes, remember it was 80 minutes, we pulled 10 minutes out. Procedures aren't bundled with the time-based codes. You got to subtract that time off of the procedures. We've used an example of the pediatrician, but the same approach is if it's a neonatologist from a different group. This IV infusion hydration is not intended to be reported by a physician or provider in a facility setting. There are transport codes. I don't get into a lot of transport codes because, first of all, if it's a non-critical transport, direction of transport, I don't think this code has any RVUs associated with it. You can charge it, but you won't get paid anything for it. If you're directing a critical care code, you can place this code in here. If you actually go on the critical care transport, you can get face-to-face time under this 99466, and you get additional every 30 minutes, you can charge additional face-to-face time. I think the last section I have in here is on consult codes. The initial day of consultation uses this set of codes, which is 99252 to to 99255. Think of pediatrician to evaluate a patient. Think of from an OB to provide prenatal counseling on labor delivery. It's time-based with a counseling rule. So if this is just simply, we went in and did counseling with the family on what to expect with a 28-week birth, you got to document the time you spent counseling. If they ask you to come back in a week, because they're now 30 weeks or 2 weeks because they're 30 weeks of age, you don't use consulting codes, you use these subsequent hospital day codes. So your first consultation, prenatal consultation, you use a prenatal consult codes. They ask you to come back in a hospital, use these subsequent hospital day codes. Not all insurers pay consultation codes. Your coders and billers should recognize that. And then there's a table by which they convert it to initial hospital care codes. So here's another graph. Looking at normal newborn. We talked about 99460 to 99463. Require the increased level of care, the not so normal newborn, using hospital-based initial codes or hospital-based subsequent codes. We've talked about intensive monitoring, 477, the weight-based intensive care, 478 to 480. Requires critical care that you're transferring using time-based codes. Requires critical care where you're assuming care, 99468 to 72. Now, I think to finish up, I did make some comments about APRNs. APRNs, neonatal nurse practitioners, depending upon the state, the scope of services they provide, and the individual hospital rules, the employer, they can independently report and bill. I think we're one of the few practices that we allow our neonatal nurse practitioners to work to their full level of licensures and bill. Just recognize that the reimbursement for a neonatal nurse practitioner is about 85% of what it is for a physician. So we allow them to go ahead and bill on their patients. If it's critical care services and they say, you know, Duncan, this kid really looks bad. Can you come talk to me about this baby? And I go in and do an examination. I put additional notation on there. If I can demonstrate and document that I have taken charge of that patient for that day, I can still bill for that rather than the practitioner. This is not split and shared services. You're going to hear people talking about split and shared services. Split and shared services don't apply to global codes, don't apply to our global critical care codes. This is the fact that two of us have talked together, we've provided a service, and I've taken ownership of the patient for that day. But recognize that depending upon the setting, neonatal nurse practitioners can bill independently. That is different from a trainee. A trainee falls under what's called path guidelines. These are set up by CMS, physicians at teaching hospital. It has general documentation, evaluation, and management guidelines. It's designed so that you get supervision for the trainee. These are some teaching settings we really don't need to get into, but the attending physician has to document that they perform the service, were physically present during the service, their participation in the management of the patient. The combined entries will substitute or constitute documentation. Now I can use a macro. I told you I use a macro for my attestation statements. Now I put my macro in and I customize it every day. What you can't do is you can't copy that forward. So the next day, and all these EMRs, they can track who did the note, what version of the note it was. So the next day, the resident will pull the attestation off, copy it forward, do the adjustments that need to be made. When I round with the residents, I'll add an attestation using my macro and then customize it to provide support for that documentation. Actually, a student can document, and we have opted not to use student documentation. We just don't think it's a good policy to have. That's an individual decision by us. We label our student notes as for educational purposes only and use the records by the physicians, residents, or fellows. Okay, it's about 5 minutes after 4. That ran me about an hour. I had some things on ICD-10 that we're not going to get into. I'll tell you that this is a quick shot of Thunder over Louisville. Louisville's known for fast horses and fine bourbon. The Kentucky Derby ran the first Saturday of May, the fastest 2 minutes of sport. We kicked the Derby off with the Kentucky Derby Festival. It's the largest air show, fireworks show in North America. They shut down 2 of the interstates. They shoot fireworks off the bridge and off of 2 barges that are in the Ohio River. Then we spend the next 2 weeks racing anything we can race. They race steamboats, they race beds, they run for the rosé with the waiters. They do hot air balloon races. They have a mini marathon race. We race everything we can race for 2 weeks, which leads up to the Derby. So I'll finish here with the fireworks. I think the